Dame Lesley Regan is the as I said, Women's Health Ambassador for England, Honorary Secretary of the International Federation of Gynecology and Obstetrics, or FIGO, and past President of the Royal College of Obstetricians and Gynecologists. And I'm told only the second woman to ever hold the role of President of the RCOG, and the first woman in 64 years to do that. And some amazing work went on during Lesley's time as President. Lesley is chair of CHARM, the Charity for Research into Miscarriage, and also chair of Wellbeing of Women, the Women's Health Research Charity. And among other, as well as doing that, Lesley is Professor of Obstetrics and Gynecology at Imperial College St Mary's, and Honorary Consultant Gynecologist for Imperial College NHS Trust. And there's many other things I know, Lesley, that you do. So Lesley will be speaking shortly, and then once Lesley's very kindly spoken about the Women's Health Strategy, we'll go on to questions, and I'll introduce our next two speakers, our panellists rather, Alison and Nikita. Lesley, can I hand over to you, please?
So I was going to tell you a little bit about the Women's Health Strategy, and particularly what we were hoping to do for women and for endometriosis, because that's been something that I've been aware of for many, many years, has been very, very poorly underserved. So I was going to show you a set of slides and try and convincing everybody of why we need a women's health strategy, and why I have bugged, I think it's, well, it used to be 2 or 3, but now I think it's about 7 or 8 Secretaries of State for Health about the need to support this. Because for years and years and years, we've had women's health seriously underfunded. And I'd argue that's not a sensible place to be when we're living in a society where 51% of women, of the population are female, and women represent 49.5% of the workforce, and they undertake over 2/3 of the nation's caring responsibilities, usually the unpaid caring roles. So there's a real importance to getting women's health right. And the thing that I really wanted to emphasize to everybody is that we need to have this as a life course approach, because as we go through every decade of a girl or a woman's life, we know that every decade that she comes to her health and well-being during that 10 years then impacts on the health of the next 10 years, and so on and so on. And during pregnancy, when women are incubating and nurturing babies, they imprint onto those babies all sorts of healthy epigenetic issues as well. So we've actually got another generation that comes out of the uterus of that woman, and it's already programmed to do all sorts of things that have been dependent on her health. And then surprise, surprise, that baby then is imprinting the health, whether it's a male or a female baby, of the next generation too. So it's really important to think about women's health as a life course. And I hope when I'm talking to something as established and passionate as Endometriosis UK, I know is that you will also share with me my frustration when I talk to policymakers and politicians who view women's health as being maternity. And I'd like to argue to you very, very strongly and persuasively, I hope as well, that that's a silly thing to do, because in the Northwestern hemisphere, women have 2 or possibly 3 pregnancies. So they can only be pregnant by definition for 27 months, even if they have 3-term pregnancies of their whole life. So they're going to spend an awful lot of their life in the non-pregnant state. And during that time, for example, most of the girls and women that you and I know will have 12 periods a year for nearly 40 years of their lives. And yet what I'm very conscious of is that it's very rare for any of us to go to a healthcare professional about, I don't know, a knee problem or a chest problem or a something else problem, and be asked, and how are your periods? And yet this is an everyday occurrence for women. And as I think the participants on this platform will appreciate, menstrual health problems are incredibly common, and they are really poorly looked after unless you've managed to get to the point of being referred to some sort of tertiary specialist, or secondary or tertiary specialist. And of course, there are some family practitioners who are extremely good and very, very switched on about all the things that they can do to help women with their menstrual health. But with that background that I've just painted for you, you won't be then surprised to understand that women who suffer from endometriosis for UK have an average of 7 to 10 years of suffering before they get a formal diagnosis. And I would argue that's just not acceptable, because we can do so much about it if we can diagnose the problem, and if we signpost that woman to the sort of services and help that she needs. And then there's another point that I wanted to emphasize as well, because it's very much to do with this life course, and we're very interested in this. And that is, in my generation of doctors, we were trained to deal with disease intervention primarily, as opposed to prevention. And what I think we've got to do is to switch the lens now to really focusing our health services on preventing problems, as opposed to waiting for them to present and then trying to put sticking plasters over them and make them a bit better. So there's another inevitability, as well as those 12 periods a year for 40 years of their life. Women are going to need good contraception for many years of that life, because as I've said, they're only usually having 2 or possibly 3 children now. And then if they get to the age of 50 or 51, there's an inevitability that they're going to become menopausal. And until very recently, and before the advent of the Davina McCalls and the Mariella Frostrups on our screen, making documentaries about their troubles through the menopause, we didn't talk about the menopause or menstrual periods. And there's still lots of other topics that I want to champion as Women's Health Ambassador that we still don't talk about, but I'm determined to show a spotlight on them. But back to endometriosis. So the Women's Health Strategy is not the first document that I've been involved with that has been trying to improve the underrepresentation of women in research, in health research, and in treatment outcomes and progress. So some of you will know I was involved with one of the publications that our only female chief medical officer, Sally Davis, commissioned back in 2014-2015, and she called it The Health of the 51% Women. And in that, for the first time, I think, here was a woman, CMO, talking about a life course approach and picking up not just on every problem that affects women, but all the missed opportunities we have to help women lead normal lives, sorting out their period problems and their preconception health, and ensuring they have the best outcome in pregnancy, but emphasising for the first time, to my certain knowledge, that women's health was not just about incubating babies and dropping them, as the Handmaid's Tale would have us believe. So we've moved past that, and during that time I was very interested, during my roles as Vice President and then President of the RCOG, to be really focusing on this, and I badgered those health secretaries, Jeremy Hunt and then Matt Hancock, and then his successors, to promote women's health and to have a strategy. And at the end of my tenure in 2019, December 2019, when I left the RCOG and handed over to my successor, we published the Better for Women report. And that had 23 recommendations in it, which were all very practical. They weren't esoteric, they weren't even altruistic, they were just practical suggestions about how we could get common sense into women's healthcare and really improve things for women and for girls. And the first of those recommendations, and the primary one, was to ask the government to introduce an NHS-led women's health strategy for the nation. And then, of course, COVID struck. I breezed into 2020 thinking I was going to spend my newfound freedom implementing all of these 23 practical proposals, and COVID struck. And then about a year later, on International Women's Day, which of course, as you will all know, is the 8th of March every year, reliably. On the 8th of March 2021, the Department of Health and Social Care launched their call for evidence and described the case for change into women's health. And I think it's fair to say, and I know some of the team are on the call or on the platform this evening, that they were a little bit overwhelmed by the response they got. Why do I say that? Well, they got 100,000 responses for women and their families from the public. And they got over 400 written responses from healthcare organisations and individuals with particular knowledge and expertise, and probably complaints as well about the women's health that they'd received. And then they also undertook some very important focus groups looking at particularly disadvantaged and marginalised groups of girls and women. And if I just give you the banner headline, and I'm sorry I can't show you the infographics because of the screen sharing problem that we've got, a little snapshot is what I wanted to show you of infographics. And right at the top of the list of causes, or rather problems, that women wanted the DHSC to prioritise and change for them were gynecological conditions and menstrual health problems. So I think that feeds right into the webinar tonight. There were some other things they flagged up as well. They wanted to have help with pregnancy loss support, and they wanted to have better help with postnatal care. But menstrual health, mental health, and gynecological chronic conditions which disabled them and prevented them carrying on with their lives was the thing that they said was most important to them. And I really cheered when I read that, because this has been something that I've been saying in my gynecology clinic for many, many years. None of this is rocket science. We can sort this out if we put the facilities in the right place to help those women. Now, the other things that came out of that evidence, call for evidence, which was very searching, was that 2/3 of the women who responded felt that their problems had impacted what they were doing in their lives, and that they couldn't go to work or finish their college education, and they were having to leave work. And this wasn't just menopausal women, this was women having problem periods, pelvic pain, and now already I'm describing the average endometriosis sufferer, if there is an average one. And the other thing that these women explained to us all in graphic detail was that only 1 in 10 of them felt that they had the right information to make the decisions they wanted to about themselves. And that's pretty shocking as well, isn't it? In a civilized society in the developed world, who has an NHS free at the point of delivery. So there were an enormous number of things that we hadn't got right, and that we needed to really think about. And possibly the one that troubled me most as a gynecologist, and I'm still working in frontline care, is that 84% of those 100,000 respondents felt that they were not being listened to, that their symptoms were dismissed when they went to see healthcare professionals, and that they weren't being given enough opportunity to ask the questions they wanted, and to also to express preferences about the treatment. And this feeds into something I've felt very passionate about for a long time. I think healthcare professionals like myself, our job is to actually explain to women all the information they need for them to make the right decision for themselves. I don't think my job is to tell people what they should be doing, or even just do things to them. I think my job is to facilitate them understanding what they can do to help be part of the solution. So the strategy was then published, and it was published in July last year. And very excitingly, I think it was written out it's a very aspirational strategy. It's going to last for 10 years. So don't jump down my throat if the bit that you want hasn't come up straight away in the first year, because we've got to actually pace ourselves. But I'm going to tell you a little bit about the priorities that we are kicking off with now. But the strategy had 8 cross-cutting themes. Because I can't show these graphics, I would just read them out to you. So women's voices was in every single one of the chapters. We had to listen to women's voices about all the topics that they were unhappy about. Information and awareness. I am determined that we are going to make the NHS website the best source in the world for healthcare for women. And access to services, something I feel very, very passionate about, because I have spent so much time talking to women over the last 30, 40 years about their problems accessing services, and in particular going to one place and getting several things done, not having to go to 4 different appointments to do something that could have all been done in the same room by the same healthcare professional in about half an hour. And then disparities in health outcomes between women. It's appalling, isn't it, to know that pregnant women who are Black have 4 times as more chance of dying than white women, and Asian women twice more. Unfortunately, in the UK, we don't have a lot of maternal deaths, but any one death is a tragedy, and invariably they can be prevented. And one of the things that was most striking about the maternal mortality report that was last published was that suicide in women who've just had a baby or are pregnant is now a leading cause of death, and that every one of those suicides was known to mental health services, and every one of those suicides had been literally a victim, because they hadn't survived, of domestic abuse and sexual violence. And that's a really, really sobering thought, I think, in a so-called developed country. Health in the workplace was another one that wanted to really, really focus on. Education and training for healthcare professionals, really important that everybody's up to date and gets access to the sort of e-learning modules and training and practical stuff that they need to be right at the top of their game. And then working with Lucy Chappell, who is the Chief Scientific Advisor to the government, and who's also, fortunately, an obstetrician and gynecologist, we really want to prioritise research and evidence, because you may be aware, or you may not, that so much of the health data that are applied to women has only been researched or designed or trialed in men. And not surprisingly, you know, men tend to respond differently to different drugs. So we've got to really, really ensure that we've got disaggregated, sex disaggregated data when we're looking at things in the future. And I'm very proud to say that NIHR, the National Institute for Health Research, has now said that if you're putting forward a study that's going to in any way impact on women and a health condition that they have, that you won't be funded unless you actually demonstrate that the data are disaggregated by sex. And a lot of other things as well. I'm pushing for ethnicity to go in there as well, because I think we've got to be brave and address the problems and the holes in our system. So research and evidence really important, and then of course data and digital. And in some ways I think COVID's helped us with that concept of data and digital. Look, we're doing everything on a platform with I don't know how many people. We may have had the odd glitch today with the slides, but never mind, I can chortle on for as long as you want without them. But the reality is that it's very commonplace now for me to see women and triage them virtually on a Zoom call or a Teams call or on some sort of NHS platform, and only make them come and travel to see me and have a face-to-face chat if they really need to, or if they need to have an investigation done or a blood test done, or if I think that there's something that they're distressed about and would very much welcome a much more intimate conversation one-to-one. So there are all those things that are going on, and we are hoping very much that we're going to be able to pull all those into place. And then I want to just tell you quickly about the 7 priority areas. Now, there are going to be lots more, but the 7 priority areas are, in order of the importance that women, those 100,000 respondents put on them, are menstrual health and disabling gynecological conditions. That was right at the top. Fertility and pregnancy loss and postnatal support. Then came menopause, then came mental health and well-being, then came cancers, and then number 6 and 7 are the ones that I worry about most, because I'm most concerned about how we're going to demonstrate impact, and that is the health impact of violence against women and girls. And I gave you some rather shocking statistics a few moments ago. Remember that there will be lots of women on this platform tonight who've been the victim of or the survivor of domestic violence. It affects 1 in 3 women, and it has no socioeconomic, no educational, and no geographic boundaries. It affects every branch in our society. So there will be people you know and people who might be quite upset by what I'm saying tonight, and we do actually have to address that fact. We can't put it away and say, oh, well, it just happens in other places. It doesn't. It happens in our society, in the UK, and tonight in London. And then the other one that I worry about is the healthy aging and the long-term conditions, because of course, what we know now is that the vast majority of women in this country will die of cardiovascular disease. And they don't realise that. They think they're going to die of cancer, but they're not. It's going to be cardiovascular disease is 52%. And then the other large contributor to maternal, to women's morbidity and death are osteoporosis and frailty, or the complications of, and of course, mental health disorders, particularly the different forms of dementia. And what we know, of course, is that women live much longer than men, but they also live significantly longer in poorer health. Now, I've said to several secretaries of state, and you won't be surprised to hear they were quite relieved when I said this. I said, I'm not planning to live forever, and they looked very relieved, but I am hoping to live for as well as I possibly can for as long as I've got. And I think that's what we would all want, isn't it, for our partners, our sisters, our daughters, our mums, or whatever. So I think we've really got to put an enormous energy into thinking about preventing, or at least postponing, these problems that are involved with long-term conditions, because you can't get rid of them completely, but you can postpone them. And I think the strategy really wants to focus on reducing that gap of the poor health years in the future, because it will make a very big difference, not just to the lifestyle and the well-being of that woman and her family and or her friends, but it will also have a massive economic impact as well. So year 1 priorities, well, there are 8 of them, and as I said, you mustn't shoot me down, well, not at this stage in the game, because I'm too early on yet, for not mentioning your particular bugbear, because we've got some overarching and very ambitious plans, but the number one is encouraging expansion of women's health hubs. And I'm sure that you will immediately see why I kept pushing for that, because of course, if you do that, then we've got all the menstrual health and pelvic pain things that immediately come in to that. Ideal for a women's health hub. Not necessarily ideal for every GP surgery, doesn't know that much about it, but ideal for a specialist women's health hub. And then the second is improving information provision on women's health. And as I said earlier, that website's got to be really absolutely tip top. And supporting women's health in the workplace, pregnancy loss, and you will hear in the very near future about providing pregnancy loss certificates for couples or individuals or women who have a miscarriage or have a baby that is delivered before it's entitled to having a birth certificate. And then fertility issues, specifically, we're going to make it easier to access fertility services and the non-clinical criteria for IVF treatment, for example, and donor insemination and ovulation induction are going to be made much more easily available. One that of course appeals to me because of my age, improving access to hormone replacement therapy and improving the pipeline of treatments for those that are suitable to have it. And then healthy aging and long-term conditions, and really giving a big boost to research and evidence into women's health for the reasons I was saying earlier. So I think I'm going to finish there. If you go onto the DHSC website, into the women's health section, you'll see a very funny video of me in the summer that was actually photographed against a black backdrop rather. And when they actually released it, it was sort of all bright pink and purple, and I looked like I'd been beamed up with Star Trek. But anyway, it's quite a nice little video. It's only a short clip, about less than a minute, talking about what we've done and what we've learned and why we're doing this, and how appreciative we are to all of the support groups and organisations that are wanting to promote women's health. And so my final words to you would like to be, before we do the Q&A, is that I just hope that you will get in contact. We want your help and we want your advice in how we can plan these health hubs and how we can best implement things. We want your thoughts about what we should be prioritising in year 2 and the following years after that. And then lastly, I would just say, I hope you all agree that we absolutely have to have a women's health strategy, and we will continue to need to have one, even when this strategy has got to its end point. And that when we get it better for women, like that Royal College of ONG report said, when we get it better for women, we get it better for everybody in society. And what I'm hoping to do in persuading our policymakers and our politicians, and in particular our Chancellor, to understand is that when we get it better for women, we can do it for much less money. And so we could actually save an enormous amount of wasted resources on helping women to do the maintenance issues that they need to get on with living their lives, rather than coming to see boring people like me when they've got a problem. So thank you.
Lesley, thank you so much. That was a really interesting explanation of the women's health strategy. I see Alison saying the same thing. A really, really fantastic overview. And we can send that link of your being beamed up video around when we do that. Yeah, and fantastic to hear. I think we all understand, obviously we want everything to happen now, but that isn't actually feasible. It's a 10-year strategy. I think for me what's exciting is it is there, that we have you as the lead of it, and I'm sure if anyone's going to make a difference, Lesley, it will be you. And I think it's really good to hear all the things that are being planned. And I think all of us are keen to work with you to look at how we can support, and again recognising we'll try not to always shout for our own corner, and recognise that we have to work together to support all progress going through. Now, we do have some preset questions and people are asking them as well. I'm just going to introduce our other panellists today who'll be doing most of the questioning. And so we have both Neelam Heera and Nikita Chandler from Cysters. Cysters is a not-for-profit specialising in supporting marginalised people with menstrual and mental health conditions. And Neelam or Nikita will tell you a little bit more about them when they start. We also have Alison Wilcox with us. Alison is Deputy Chair of Verity, the charity for those with polycystic ovary syndrome, PCOS. And so Verity aim to educate, support and empower those with PCOS. And again, Alison will say just a little bit about that. So Nikita or Neelam, would you like to introduce the charity and yourselves, and then we'll kick off with the questioning.
Thank you, Emma. Hello, everyone. My name's Nikita Chada. My pronouns are she, they, and I am a trustee, speaker, and lead facilitator for Cysters. Cysters is a community-led charity, and we support minoritized individuals and communities with reproductive and mental well-being. We were founded in 2015 by Neelam Heera, and intersectionality lies at the heart of what we do as an organization. And we want to always ensure that the most minoritized voices are being heard within wider conversations around healthcare and healthcare inequality. We strive for equal access to healthcare for marginalized communities through education and awareness, leading to informed and empowered decisions for treatment options and pathways. Thank you.
Thank you, Nikita. And Alison, would you just like to introduce yourself, and then I'm going to hand back to Nikita to start questions.
Fantastic. Hello, good evening, everyone. And it's absolutely lovely to be here to represent Verity and those with PCOS. So at the moment, my name is Alison Wilcox. I'm a trustee deputy chair. Verity, as you've said, is the national charity, which we're very proud to represent all those with PCOS. We've been going for 25 years and we cover England and Wales. Personally, I work for the NHS. I'm a qualified occupational therapist, and I'm currently running an NHS England long COVID service for the last couple of years. And we're delighted to be on this webinar this evening. We've had the privilege of working with Dame Lesley in previous, kind of projects and things like that. And obviously we're delighted that we complete some joint work and collaborative work with Endometriosis UK.
Thank you, Alison. And so I know that Cysters and Verity and ourselves have been out asking people questions to start things off, and quite similar actually, some of them. So Nikita, should we start with you? And you had some questions on your sort of asking Dame Lesley about her thoughts and priorities for the strategy.
Yes, thank you, Emma. My question to ask is, what excites you the most about the strategy?
Well, that's easy, because I've been a gynecologist for about 40 years now, a little bit longer, in fact. And we have never before had a government that has said that they're going to prioritise women's health and agree to have a strategic plan. So whatever you think of the government at the moment, they've committed to that. And I think that I must do everything I possibly can in my power to use that opportunity. I often say, particularly the people I've trained, opportunities rarely make appointments. You actually have to grab them or you miss them. And I also think that we've entered a crisis, an economic crisis of rather strange making in the last 6 months. And I also am a very strong believer in that you can always get something good out of a crisis if you look hard enough. So I'm hoping that my belief that we can do women's health so much better for less money will be if you like, the switch on the dial that will allow us to get the go-ahead to do so many of the things I want to do. Because as I said earlier, and I'll repeat again, I'm not suggesting super fantastical nuanced genomics and very expensive tests and imaging. I'm talking about very basic healthcare maintenance issues that we do very badly at the moment for all sorts of historical reasons. And so I want to have a reset. And I want you, Nikita, to feel that when you go to a women's health hub or to somebody that you've trusted to help you with your various problems, whatever they may be, that they will wrap the services around you rather than making you run around the different places. I get very, very frustrated by having to tell women who I've just examined in an intimate way that I can't do all the things that they need in the same examination because of commissioning rules. So we've got to stop that. We've got to use common sense. And, what better than to get a bossy woman to be trying to sort that out.
Thank you, Dame Lesley. I'm going to go into the next question, if that's okay. The next question I have is, what would you love to see more of from the women's health strategy?
Well, what I want to hopefully achieve is that we get sustainable changes. because there's no point, well, put it this way, I've done a lot of global health in my time as well as national health for women. And what I've seen time and time again is that people metaphorically helicopter in, do marvelous things, save lots of lives or improve people's lives, and then they disappear again because they haven't implemented the system, or they haven't implemented the improved care into the system. So I'm an absolute believer is that you don't improve women's health sustainably unless you garner and harness political will, and unless you improve female literacy and education. So I think those are the two things that I really want to achieve. Now, if you go out and say that, they say, oh God, we don't want her talking about that. But in the sidelines, that's what I want to do. I want to really advocate for the importance of women's health, improving society. And in my book, advocacy means changing hearts and minds. It means persuading people to think and then to act differently. And I also really want us to focus on improving female literacy and female education about the things that women and girls can do for themselves. Because I really do believe that women are part of the solution, and that if we don't recognize that when you tell women how they can help themselves, that they don't keep the information to themselves, they invariably tell everybody around them that they know, not just the girls and the women, but the men as well. So I think they're fantastic ambassadors. And as I said to somebody else earlier today, we've got a population, I believe, of about 64 million in this country at the moment, and 51% of us are women. So if we could get every one of those women, we'd have on the, what would it be, about 36 or something like that, 36 million mini ambassadors. And I don't think that could get better than that. So I think we've got to make women part of the solution as well. And that's what I very much hope that we'll be able to inculcate. It's not so much implement, because you can't make people do things, but you actually encourage everybody to feel that they've got a part to play in helping, if they're men, helping the women in their lives have better health, and therefore a better quality of life.
Thank you for those. Alison, I'm just thinking your next question was about top 3 priorities, but I think Dame Lesley's actually given us a lovely 7 and 8 priorities. So can I ask you to move on to your next question around the awareness of the strategy? You're on mute, by the way.
Okay. So Dame Lesley, we posted in our Facebook community that we had the privilege to be on this panel this evening. And it seems regrettably there's kind of a little awareness of the women's health strategy for England, and we're just wondering kind of what things and you know, things are in place really to kind of get people to kind of get to know about this strategy more at all levels. You know, so I'm just kind of wondering kind of what's going to happen, or what is happening, so that this strategy becomes known to more people.
Well, it's disappointing to hear that that's what people think. I mean, I'm not being facetious, but I seem to be talking about it most hours of my life. So I just obviously, I'm not targeting the right people, but I've done a lot of radio stuff, and I've done quite a bit of TV stuff as well. Yes. We can certainly think about getting some more articles written and published as well. But I'm very conscious of the fact that I'm talking in a very old-fashioned way, aren't I, about giving a talk or writing an article, and that we've actually got to think about different ways to communicate, and particularly if, as is one of my priorities, to get younger women to think about what they can do to get the trajectory of their life course better. And you know, handing them a sheet of A4 paper is not going to be helpful, is it? Because well, I don't like A4 anyway, because you can't get it into your handbag, so you tend to not take it anyway. But I like A5 because you can usually get it. Well, I can always get it into one of my handbags because I have big ones. But A5 is good, but that's actually not how to be doing it, is it? We need to be on TikTok and Facebook and Instagram and all of those things. And I think, therefore, what my role is then is to reach out to other individuals who've got access to those groups who are more difficult or finding it more difficult to access services. And I'm not going to call them deliberately, I'm not going to call them the more difficult to reach group, because as I keep saying to the women's health team working with me, let's stop using that phrase and let's talk about the fact that these are the groups of women it's been too easy to ignore for too long.
Yes, yeah. Absolutely. So just to assure you, obviously as us as charities, we'll be obviously one of your army of ambassadors out there to kind of profile and promote. So please be reassured.
Okay, and then if women, if anyone on the call, for example, or any of you, if you put it on your website or whatever, if they email Women's Health Ambassador at dhsc.gov.uk, I'll put it in the chat in a moment, then there's the team will pick up those emails as well. I have to say, we've been deluged by offers of help. So I find that quite encouraging, actually. I mean, some of them a bit off the wall, but, you know, not to worry. I have replied to all of them saying, well, we'll get round to it at some point. But I think I've met an enormous amount of enthusiasm. So I think that's the other thing which makes me feel very positive about this. Most people I've spoken to haven't said, oh, God, why are we doing that? They said, what can I do to help?
Absolutely. So in some senses, as charities, you know, individually and collectively, we can do so much, you know, for this. And I'm just wondering what kind of, you know, if you're going to give me some things to go off and do some quick wins to help support you, the role, and obviously this massive population, what can we do quickly to help you and help others quickly?
Well, I think promote the strategy and the importance of it, and actually be including all those links. There are lots of things out there, and they're not all densely written things. There are graphics, there are video clips, there are all sorts of things. And to link up with some of the team at the DHSC and to help us get the best traction we can. We've just embarked on a very comprehensive set of roundtables where we've included as many people as possible. Don't worry, there hasn't been one about menstrual health so far, so you haven't missed out. But we had a very interesting one last week about musculoskeletal disorders. Of course, one of the other reasons I'm so enthusiastic about this myself is that I get to learn all sorts of things that I didn't know. I mean, you know, I know quite a lot about gynecology and reproduction, but I didn't know about all these extraordinary things that you can do for musculoskeletal wellness and health and well-being. So it's a learning curve for all of us. And once again, those MSK people who are just one of the many groups, particularly in that long-term conditions that I flagged up that I think we're going to need a lot of help with. But they were very, very enthusiastic and very generous with their time and their offers of help.
Thank you.
Thank you. And for Anita, who's asked, as a young woman with endometriosis, how can I contribute to help raising awareness about the strategy? Hopefully that's given you some answers, and Anita will look at with Dame Lesley's team about what is it we as a charity have responsibility and can help provide information as well. And I think, again, taking on board what Lesley's saying about it's not just about doing a leaflet and hoping that gets out. It's about actually how do we make an effort to try and reach people in a way that they want to see, you know, they can receive information. Carrying on, Nikita, we had some more questions from Cysters. Would you like to carry on?
Thank you, Emma. Yes, we've got two from us. The first one being, especially knowing that we are a community-led organisation, is how can communities be involved in shaping and feeding into this conversation to ensure that the strategy is working?
Well, it's a very good question, and I'm delighted you've asked it, because I think what's really important here is that we as a women's health strategy team go out to those groups, as opposed to saying, oh, we're going to have the meeting at number 39 Victoria Street and they've all got to come here. So I've been working with quite a few individuals who, most of whom you probably know, who have been very interested in, well, who've got great expertise, shall I say, and knowledge about how to reach some of those more marginalised groups and those groups of women that don't tend to find it easy to go and see a gynecologist or to talk about these things. And we really want to promote that. And as I say, we've ditched the difficult to reach and we're not going to ignore them. So, I mean, I've been working with Nigat Arif and various other people who've got enormous expertise in, for example, in the group of Muslim women who find it extremely difficult to access contraception and menopause care and don't have access to the sort of information that they need. So I think a lot of this is about actually providing women with the tools that they need to understand what they can do to help themselves. Because I want to keep emphasising that most of what women access from healthcare professionals during their life course, they're not ill. They're just trying to do ordinary, everyday things, and they're trying to remain as well as possible. So they're looking for maintenance services. This is not, major surgery, or, very expensive new drugs. This is about basic stuff. So I think that we've got a lot of plans to be talking to smaller groups and ethnic groups in particular who have particular issues and need help to be delivered to them in different ways.
Thank you. So I have just one last question in this section from Cysters, and I think it's particularly important considering the global and political climate. But the strategy doesn't consider trans and non-binary people. So what can we do to support those groups?
Well, there is an overarching comment at the beginning of the strategy about how we are, how we are not disadvantaging anybody who needs their help. I mean, as I said, I've been a gynecologist for a long time, and I have looked after lots of trans individuals, and I've always worked on the principle that if you walk through the door and you say that you need me, or you need me to explain something about what you might need in the future, I don't mind how you define yourself, I will look after you. And I think I can only convince people of that by example. And I think that it's so far, I mean, I've found that that's always been quite an effective way to communicate with my patients. And I'm sure that there are many people who feel like me about it. But that it is, Nikita, it is mentioned in the strategy that we are including everybody and we are not excluding anybody.
Thank you. Moving on to a slightly different area, if that's okay. You mentioned, Lesley, about women's health hubs, and a few people asking about actually what will they do, and they sound very exciting. Could you just say a little more about sort of what a women's health hub is and how it would help, for example, with diagnosis and treatment of conditions?
Well, the first thing I want to say is that a women's health hub isn't one size fits all. So what you need in my patch in Paddington, where I work, is going to be different from what you are going to need in a rural environment or in a prison or in a seaside deprived area. And I will also want to really emphasize that this health hub doesn't have to be a place either. So we have obsessed, haven't we, since the 1948 when the NHS came in, that healthcare is done in buildings that are staffed by people, in patients or women in this case, who are not ill but just wanting help to maintain their health, have to visit. And I don't think that's necessary. And I think that's carpe COVID, isn't it, really? We've actually taught ourselves that we don't have to do that all the time. So I think that there will be lots of hubs that are virtual. And perhaps, for example, Emma, you might log on to have a consultation with me. And then at the end of that discussion, where you've been able to bring up 3 or 4 things that you're worried about, not just one that's only allowed 7 minutes for, several things. And then we agree that you need to go to a particular site because we think together, you and I, that you need to have some blood tests, or you need to have an ultrasound scan, or you need to have a mammogram, or you need to have a particular type of imaging that's not possible with a portable machine. So there'll be different types of health hubs depending on what's needed. But the triage, the virtual triage, I think is going to be important. And then there are going to be some women, of course, as I mentioned earlier, when I'm on a virtual call with a patient, with a new patient, who I realise probably does need to be seen, or I get the sixth sense that there's something else going on that they will need to be seen face to face with. Now, I don't get that perfect 100% of the time, but experience has told me that I get it right a lot of the time. But I think then there's an opportunity to not waste your time, Emma, by sending you to a secondary care facility where they haven't got the right infrastructure, or they haven't got the right resources, or they haven't been commissioned to do this. I think the health hubs should be thought of not as buildings, but as a signposting service, and that we signpost the girls and women to where they need to go to get what they want. And it will be much cheaper to do that.
Music to my ears, both personally and at work, in terms of Yeah, I'm sure we've all been round the houses and the multiple appointments at different times. So that I think that's going to be a really interesting development going forward. We're going to move on. I'm going to move on now. Nikita and Alison, we are going to run out of time. We're not going to be able to answer all our questions. So could you pick the next question that you would like to have answered? And I'm going to start with Alison, if that's okay.
You're muted, Alison, but just while you're unmuting, I mean, if you want to send the other questions in, I'm sure we can have a little look at it. It won't necessarily be done this week, but I'll do my best to answer as many as I can if you send them to us.
Thank you.
So actually, Dame Lesley, you've answered quite a few already, to assure you, from the discussion about the women's health hubs, because I think this has really sparked a lot of interest and, you know, focusing people to have that kind of more coordinated, integrated care. Absolutely. I think obviously it's the kind of, obviously they're going to get established, and it's alongside that about the training, education, support to the professionals who will be helping to run those, you know, hubs, virtual and hybrid, etc. So it's about kind of how we give ourselves the assurance that those professionals will be, you know, educated and kind of, you know, sympathetic and listening, and also supportive, because they've had additional training and support to enable that to happen.
Well, I think there's a lot of things I could say about that, and then we'll run out of time completely. But one of the things I'd like to reassure everybody on the platform about is that there are women's health hubs up and running, some of them being piloted at the moment, and we are working with a great team at RAND in Birmingham who are actually analysing these different models of health hub. And what I find particularly encouraging whenever I talk to Becky Taylor, who's running this and leading the analysis, is that every time I talk to her, the number of health hubs has increased. So they've discovered more. Or someone said, oh yes, but there's one of those there, but nobody calls it a health hub. So we started off, I think, with 11 when we commissioned them to start looking into this and to give us some really helpful feedback about what works and what doesn't work. Because remember, we all think that we want to get the perfect solution, but I've personally found that I learn far more from the things I get wrong or the things that don't work out than the things that do work out. So what I'm hoping is that, you know, I can't promise that we won't make mistakes as we go forward and implement these hubs, but let's not make the same mistakes as some of the hubs did, and actually learn from their experiences and make different mistakes, and we'll all travel a lot farther and a lot faster if we do it that way. But there is going to be an analysis which is coming out at the end of March or the beginning of April about those hubs, and I think that will be really, really helpful. And then the team and I are working at the moment on pathways for a variety of different problems, not so much a particular illness or a diagnosis, but, you know, what does good look like when a woman comes to your health hub and says she's got pelvic pain or she has cyclical pain every single period time. So you don't have to have a diagnosis in that, but how can that healthcare practitioner then follow them, or rather signpost them along a pathway to get the help they need to get a diagnosis quickly? So we're working on those, and as you will realise, because women's health is a very large area, there are all sorts of pathways that we need to work on. But again, I've been impressed by how generous people have been. You know, they've shared, they sort of just send me in an email attachments, which has obviously taken them months and months of their professional expertise to work up. So again, there's enthusiasm to share. And I think I'd finish that comment, Alison, by saying that what I've learned during my career is that you can travel an awful lot farther and an awful lot faster if you don't keep bothering about who's getting the credit along the way.
Point there, Dame Lesley. We've only got a couple of minutes left. So Nikita, do you have one relatively quick question you could ask?
Yes, I'm going to ask I think the one that's quicker to answer out of the two. And really important considering that we're a grassroots charity and that a lot of different people make up the movement. How will we ensure that the Women's Health Strategy continues to work with grassroots organisations to support all communities?
Well, all I can do is promise you that whilst I remain the ambassador, that will continue to happen. So I was asked by one of the Department of Health teams at their away day, in fact with the mental health team a couple of weeks ago, what was the problem with the DH and the civil service? And I said, well, I think there are two speeds. It's go slow and go very slow. And they said, well, what are you going to do about it? And I said, well, I think my job is to make sure we never stop. But I promise you, Nikita, that whilst I remain the ambassador, And that's obviously an appointment, so I can't promise I'll always be there. But whilst I remain the ambassador, I will ensure that this is woman driven or women's voices driven, because that's actually what's been missing from our health services for far too long. And women have not felt listened to. And as a result of it, we've done things to them and told them what they need, as opposed to listening to what they want and giving them what they need in reality. So I can only promise you that that's what I will achieve. And I'm very comforted by the attitude of all of the people working with me at the DHSC, and interesting at NHS England as well, and in the Cabinet Office, who actually feel that is a very important priority to maintain. So I do feel confident that we will, if we collaborate, all of us, and as I say, don't keep worrying about who's getting the credit for this, that and the other, we will be able to continue to progress, and that we will go from strength to strength.